Dear Chair, dear audience, I would like to present my PhD topic, which is the link between cognitive training and neuroplasticity in mild cognitive impairment. I'm Eszter Radics, my supervisor is András Horváth, and my SMS is Mari. My vision is that all preventable dementia cases are prevented, and my mission is to evaluate cognitive trainings to delay or prevent dementia. In order to achieve these goals, I have two projects going on. The first one is titled Morphological and Microstructural Brain Changes Induced by Cognitive Training Are Not Evidence-Based. This is a systematic review and a meta-analysis. And the second one is titled Advancing Initiatives of Dementia Risk Reduction, which is a survey. So about the first project. As you may know, dementia is on the rise and will affect 139 million people by 2050. But different lifestyle interventions show promising results. Recent studies showed that at least 40% of all dementia cases are linked to modifiable lifestyle and environmental factors. And we know that a wide range of cognitive trainings exist, but their exact effect on objective neural parameters is still unknown. So our question was, how do they affect these parameters? The clinical question was exactly how does cognitive training influence structural and functional network connectivity in the brain? Our population were adults. The intervention was designed and validated cognitive training. The comparator was no designed and validated cognitive trainings. And the outcomes were objective markers of cognitive risk. Our hypothesis was that cognitive trainings have a beneficial effect on the brain compared to no intervention. And if this is true, clinical and research implications would be delaying and preventing dementia and designing better trainings. Here you can see the systematic search key. We did the search at the 30th of November 2023. We had 3 domains. Here's the flowchart of selection. We ended up with a bit more than 6,000 articles and ended with 8 eligible full texts. Our outcome measures were mean differences and standardized mean differences with 95% confidence intervals. We finished all analyses, which were white matter integrity and hippocampal volume. So about the first outcome. Fractional anisotropy is a diffusion tensor imaging derived measure. It is a scale between 0 and 1, where 0 means that diffusion is equal in all directions, which means reduced structural integrity, and 1 means unidirectional diffusion, where aligned fibers and white matter integrity. This measure is sensitive to white matter degeneration in the early stages of Alzheimer's disease and MCI. Here you can see the plot, the first plot of this result. We investigated 115 people in this plot. The effect of 0.01 is not mathematically significant, and also clinically it's not significant. You can also see that the heterogeneity between the studies is really high. It's 87%. So yes, there was issues with heterogeneity. You can also see the risk of bias assessment on the right. Our other outcome was hippocampal volume, which is associated with late life cognitive decline. Smaller hippocampal volume is associated with poor cognitive functions such as working memory, processing speed, and verbal learning. And these domains are particularly vulnerable to decline in non-pathological aging. So that's why we choose this outcome. Here you can see the first plot of this outcome. We investigated 290 people. The result of 0.02 is again not statistically nor clinically significant. And here the heterogeneity is 0%, but from the wide confidence interval you can see that it's probably much higher than that. And you can also see the risk of bias assessment on the right. We finished this manuscript. The strength of this paper is that, to my knowledge, it is the first meta-analysis assessing these outcomes, and we followed our protocol and guidelines of the PRISMA and the Cochrane collaboration. And our limitations are that there were huge baseline differences, there were issues with randomizations and stratification, we had very small sample sizes and high heterogeneity between the studies. So to conclude, the benefits of cognitive training seen in neuropsychology are not that evident on objective markers, and to prove their efficacy, more and better design research is needed. Our implication for practice is that adjusting recommendations of cognitive trainings not to imply they are symptom delaying or preventive methods. And for research, better randomization, ensuring no baseline differences, and stratification for cognitive research would be very beneficial, and the usage of multiple follow-up times as well. This article is currently under review in Alzheimer's Research and Therapy, which is a D1 journal. And this is my second topic. This is a survey that so pathological changes of dementia start 20 and 30 years before the onset of the disease. And so early biomarker testing could enhance the benefits of preventive methods, although it is challenging to communicate these results to patients. And we believe that personalized patient and clinician communication could lead to more efficient health and disease-related behavior, as well as a better quality of life. So investigating the differences between European and Hungarian protocols could be beneficial in improving the health system. So here you can see the clinical and research implications, understanding clinicians' perspective on biomarker testing and improving national health care. About the methods, we are implementing the latest survey in the Hungarian population. This is a Dutch study that investigated clinicians' perspective of early biomarker testing and communication strategies. And we are updating this survey according to the 2024 guideline of Alzheimer's diagnosis, and we are extending this to general practitioners. And you can see how that survey looks like, the original one. So in summary, I have these two ongoing projects. I've submitted the first one in April, and I'm planning to submit the next one in October. And my additional activities, I'm doing neuropsychological assessments with stroke patients at the Department of Neurosurgery and Neurointervention, Semmelweis University. And I would like to thank you for your attention with this really long quote of Aldous Huxley. Systematic reasoning is something we could not as a species or as individuals possibly do without, but neither, if we are to remain sane, can we possibly do without direct perception, the more unsystematic the better, of the inner and outer worlds into which we have been born. Thank you very much for your attention.
So, the first study was essentially an absolute negative study.
I'm sorry, say?
Absolutely negative study.
Yes.
Still, you plan to publish in a high-ranked journal.
Yes, because we believe that's an important result anyhow.
I wish I could come back next year to see.
Well, we'll see. We'll see.
I do have a question, sorry.
Sure.
Okay, so in your first study, how long were these trainings?
Yes, they were very different length. Some of them were just, I don't know, 9 weeks, and some of them were 8 months. So that also, again, accounts for heterogeneity between the studies. But usually they are 2-3 months, most of them.
And because I was wondering, 2 or 3 months are not a long time
Yes.
period, and I would assume that changes in brain volume happen over a longer period of time. So I'm not sure are these objective methods are appropriate to evaluate these kind of changes. Were these outcomes validated in other types of research?
What do you mean by other types?
Or in what kind of other research did they use these outcomes, these brain volume changes?
Well, these are really important factors in Alzheimer's research. I'm not sure 100% I understand the question.
What I want to ask is, so you try to assess the effects of functional training, cognitive training on the brain volume change.
Yes.
And what other kind of studies? So what kind of other interventions did they measure with this brain volume change outcome in other studies?
Well, I think they measure this with a lot of kinds of studies, with a lot of populations. So I don't know what to answer. But I can say this, that some studies had multiple follow-up times, and usually it was visible that even if they had a bit of difference, like positive change in the brain volumes, it was lost after a couple of months. So another implication for this would be that it is not enough to do it for a short period, but you have to do it again and again or continuously in order to achieve any kind of changes. But even then, it was not significant.
Thank you.
I have a question regarding this fractional anisotropy. Is it measured in the same way in the different studies? So they calculated exactly the same?
As far as I know, yes, there was not very much differences with fractional anisotropy, but we had a lot of other outcomes that we expected to include, but could not due to these differences like functional MRI and positron emission tomography. Yes, these.
And what do you think, if there is a difference in the anisotropy, what could be the clinically minimal relevant change? Yes.
Yes, I was searching the literature and other meta-analyses and studies usually stated that a change of 3 to 5% would be clinically significant. Yes, and for hippocampal volume, that would be like 2% already, but it's not seen. Yes, it's very small. Well, also it declines with age, right? So when you get older, you get smaller hippocampal volume. So even if you can just reverse this decline, that's already a big thing.
Yes. So my question is maybe from a clinical standpoint, let's say, or maybe even from a public health standpoint. We can't really do much for people with dementia or with mild cognitive impairments. At least that's my impression. You can disagree, and I would be very happy if you can. What is the best course of action? For a person in their 80s. Let's say beginning of their 80s, they do have mild cognitive impairment. We know that it's probably going to progress. What should be the advice? Should they go through all the examinations? Should their cognitive decline be quantified? Should we try some interventions on them? Can we help them? What can they do to help themselves, and what the medical profession can do to help them?
I think that's a lot of question of kind of old people also. I mean, yes. I think it's better if you are starting testing earlier, like much earlier than 80 years old people, because the pathology starts way earlier. And even if we had the money, we could test everyone to have blood biomarkers and amyloid, and we could say that yes, you are in a very high risk group. And the earlier the intervention starts, it's the better, it's the best.
What kind of interventions are effective for such instances?
Well, as we see, this one is not. But there's a lot of risk factors, so that's very important. I don't know, you should not smoke, obviously. Physical exercise, actually, there was a meta-analysis with physical exercise training, and that was significant, so that's very good. And it actually helps more than cognitive training. Also, your vitamin B levels are very important, sleep. So there's a lot of things diet that you can affect, but obviously the pathology you cannot change. I mean, right now we don't know how to do that, so that's a sad part.
Thanks very much.
Thank you.
Yeah, I enjoyed that. Is this on? I don't. It's on. Yeah. So on there were two things really. The first thing was, why did anybody ever think doing cognitive training would make parts of your brain grow bigger? Like, where did that idea come from?
Well, actually, we see really promising results from neuropsychological tests. So, like, obviously, most of the studies include neuropsychology as outcomes and not these hard outcomes that we were using. That's why also we ended up with 4 studies. And on those, we can see that it really benefits. So we are not stating that people should not advise these trainings. We are just saying that this is not changing the pathology of the disease. But also, these studies investigated the effect on daily life activities of patients, and it was also beneficial on that. So they can get better memories and executive functions, probably with other parts of the brain taking up these duties.
No, that makes perfect sense, that you get functional improvements or a slower functional decline or preservation of activity.
Yes.
But you know, the idea that by doing Sudoku, it'd be like doing bench curls, it seems crazy. You know, that your brain would get bigger like a muscle. You know, but the function thing makes sense. That all makes sense to me. You know, Sorry, you were going to say that. No.
I wanted to say 2 things, that also on anxiety and depression scales, it really helps patients, and that, well, as I said, physical activity actually helps the brain grow. So why would cognitive training not? I mean, I had the idea that it could.
Okay.
And yeah, I thought it makes sense.
So my second question is really on this. What was on your second project, which is really like a kind of screening for at-risk people for dementia.
Yeah.
Or how would you kind of identify high-risk cohorts, essentially?
No, we are surveying clinicians.
Yeah, to see how they would identify high-risk cohorts.
No, how they, like what kind of, let me go back to that.
Yeah, thank you.
So there are different kinds of questions in this survey. Here you can see that they are asking what kind of tests are available at your center. So the current guideline of Alzheimer's diagnosis has multiple assessments, and it is not 100%. There's not a gold standard how to diagnose Alzheimer's, right? So that's what we are surveying here. Also, in the last couple of years, actually last year, there was a change in this, and fluid-based markers entered. Like blood markers.
So these are people with cognitive decline, and you want to categorize their, they got Alzheimer's, have they got frontotemporal?
Yes, how you diagnose and this kind of stuff. How you communicate about, even if it's not diagnosable yet, are you saying that you are in a high risk, blah, blah, blah? How are you communicating this with the patient?
Okay, no, I understand that. So it's useful to have a unified approach across Hungary. And Hungary differs from other EU protocols, is that correct at the minute?
Actually, I'm not 100% sure, as I'm not a clinician myself. But I believe so, yes. I'm sure that about the availability of these assessments, there's big differences across Europe. But about the protocol, that I think everyone is following this guideline. That's an international guideline. But it's very personal how you interpret.
Yeah. Okay, thank you.